dermatology. And I sincerely thank at the very beginning, all the faculties who have joined today, particularly Professor Dr. Carsten Flohr from London. He has always been very supportive for our society, and he is on International Advisory Board. And this I think is the second appearance of him, virtually. But for anything, anytime we have asked for from the society, he has always been very cooperative. My sincere thanks on behalf of entire Society for Eczema Studies to, Professor Carsten Flohr. I sincerely thank, Dr. Sushil Taliani, Dr. Sanjeev Kandari, Dr. Sachin Verma, and Dr. Avijit Saha for being here today. Today we are going to talk about cyclosporine, but before that I must say a few words about Society for Eczema Studies. This is the society which was established on 29th of March last year, 2022. So this is more or less 1 year, 5-month-old society, and we have done quite a good number of academic exercises. We have launched it across India in various cities, even abroad in different countries, wherever I have gone as a speaker. So I have launched Society for Eczema Studies there also. And we have got a very good response. And right now we are doing a couple of projects, multicentric projects on atopic dermatitis. Basically, the society focuses on atopic dermatitis, but also contact occupational dermatitis too. We have given 3 thesis grants to our postgraduate students last year, and we plan to continue it every alternate year. And we have done a very successful national congress last year, and another congress will be in 2024. We are actually basically interested for doing research, education, and bringing out the data from Indian context, which is, the area where we have got weakness of our data and our publications. That is exactly what the SES plans for. With this, I shall switch over to today's, program's context setting. The cyclosporine is a very important, consistent molecule over the last 2 decades. What is its current position, and how do you use it in different pediatric dermatological conditions? That is exactly what we are going to speak about. So, at the end of, mine as well as, Carsten's lecture, there will be a panel discussion with all the panelists. And now I'll hand over the platform to Dr. Neera to introduce the speakers. Thank you.
A very good evening and a warm welcome to each one of you. At the outset, I would want to thank Dr. Sandeep Pandhar sir and the Society of Eczema Studies for giving us this opportunity to collaborate on this wonderful opportunity, the scientific initiative that we are running in series, and today we are at the 3rd of that. I'm Dr. Neera Gupta, and I support medical affairs for immunology and oncology at Biocon Biologics. It's our honor and privilege to be part of this program. I would want to introduce that how the flow of the program is. We have our first speaker, Dr. Sandeep Pandhar sir. He is professor and head department of pediatric dermatology, Institute of Child Health, Kolkata. Sir will be speaking about cyclosporine in a dermatology, a case-based discussion. We have our international speaker, Dr. Carsten Flohr. He is head pediatric and population-based dermatology research, St. John's Institute of Dermatology, London. He will be talking about using cyclosporine and methotrexate as first-line systemics in severe pediatric atopic dermatitis, lessons from pre-trial. Followed by this, we'll have a panel discussion wherein we have our esteemed moderator, Dr. Sushil Taliani, sir. He'll be leading the moderation for role of cyclosporine in immunodermatological conditions. Dr. Taliani is consultant dermatologist, PD Hinduja Hospital Medical Research Center, Mumbai. Dr. Sanjeev Kandhari, sir, our elite group of panelists includes Dr. Sanjeev Kandhari, sir. He is the leading dermatologist, senior consultant dermatologist, Dr. Kandhari Skin and Dental Clinic, Delhi. Dr. Sachin Verma, Chief Dermatologist and Cosmetologist, Skin Vita Clinic, Kolkata, and Dr. Abhijit Saha, Institute of Child Health, Kolkata, the leading dermatologist. We are marking a milestone year this time for cyclosporine because cyclosporine first got approved in 1997 for dermatological condition. And this is the 25th year. And as we move on with this journey, we are happy to share that more than 1.2 lakhs people in India, they receive cyclosporine in a year. It's wonderful to see how this drug has been developed and taken the journey going forward. And with this, I will invite Dr. Sandeepan Dhar sir to talk about his talk. Thank you, sir.
Thank you very much, Dr. Thank you very much, Dr. Neera, for all the kind words. Friends, I welcome all of you. Yeah. Is it visible?
Excuse yes, sir.
Me? Yeah.
Yes, sir.
Thank you. Thank you. Well, I'm going to talk about cyclosporine in dermatology, a case-based discussion. This is the collection of my experience over last 2 decades. I have been prescribing cyclosporine for various conditions. I don't have any conflict of interest in this presentation today. A number of conditions where I have used, actually the list is huge, but this is for all practical purpose, the conditions where I have used cyclosporine. As you can see, psoriasis and atopic dermatitis topped the list, but there are other conditions also where I have used it. Maybe that because of the constraint of time, I won't be able to share all the conditions here, but just listing here. But I shall share, photographs of the patients before and after in some important dermatological conditions, mostly pediatric, but adult also in a couple of cases. So this is a review article authored by few of us on the role of cyclosporine in immunodermatological conditions, which was published last year in Indian Dermatology Online Journal. And those who are interested in knowing about the cyclosporine and how it should be used, where it should be used, what are the cautions and precautions you have to take in Indian setting, I think this article may be handy for them. So where exactly we use cyclosporine in psoriasis? We use cyclosporine in psoriasis as a monotherapy in moderate to severe psoriasis, or pustular or erythrodermic psoriasis during acute flare of the disease. We can use it as a combination therapy also with methotrexate for short period of time, because cyclosporine is a costly molecule. Many people cannot afford it for long-term purpose. Use it for initial few months. Then once the disease is under control, switch over to methotrexate as a maintenance therapy. I'm sure more detail will come from Carsten about the cyclosporine versus methotrexate in the very famous trial he conducted, the TREE trial. Now, in psoriasis, we use by and large in a dose of 3 to 5 milligram per kg per day, considering the ideal body weight. There are two methods. One is step up, gradually you increase the dose. Another is step down approach. I personally believe, and I have used in maximum patients, you can say, for example, for 90% of this patient, step down method, because my perception is that cyclosporine is used for a very severe condition of a disease, whether it is psoriasis or atopic dermatitis. So you have to hit hard and hit with maximum, strength and swiftness. So there is limited scope of switching, gradually stepping up. You try with the highest dose, and then once the disease is controlled, gradually come down the ladder. That is my approach. And the tapering should be 0.5 to 1 milligram per kg every 3 to 4 weeks. It can be chronic versus intermittent use. I am sure during the panel discussion, all these questions will come up: sequential therapy of cyclosporine, weekend therapy, and all these things. So many of these things I won't discuss now, so that we can discuss during the panel discussion, as well as I am also able to finish my talk within the stipulated period of time. Now, cyclosporine versus methotrexate. Cyclosporine and methotrexate both are found to be quite effective in both psoriasis and atopic dermatitis. But as far as the control of the severity of the disease is concerned, cyclosporine has an edge over methotrexate because it controls the disease very fast within 7 to 10 days, whereas methotrexate takes at least 4 weeks or 4 to 6 weeks. Cyclosporine in psoriatic erythroderma. Here there are, cases which I am going to share with you. This is a 5-year-old boy with psoriatic erythroderma for more than 1 year. This unfortunate child was not allowed to go to school because the other parents complained that this might be an infectious disease, and this we have to face day in and day out in pediatric dermatology practice, whether it is atopic dermatitis or psoriasis. Often there is rejection of the child in the school, and I regularly write for the principal a letter that the child should not be discriminated. So this child, parents actually were so depressed, not only for the disease of the child, but also, the rejection of our so-called civilized society. So the child was put on 5 milligram per kg per day of cyclosporine. That is one of the good dose of cyclosporine. And see what happened after 10 weeks. It completely cleared. As you can see, the child smiled, the parents also smiled, and most important, the child was taken back in the school again. It can change the quality of life, in a huge way. Here there is a 7-year-old boy who was referred to me by a pediatric nephrologist because the child had, nephrotic syndrome, for which the child was on oral steroid. That time it was 20 milligram, gradually tapered after a few months. And the child, when developed these lesions, the pediatric nephrologist and pediatricians thought it is a tinea or dermatophytic infection, which is very common in our country. And they, they started directly on topical antifungals and even oral terbinafine, and hardly anything happened after 3 to 4 weeks. Then the child was referred to me, and I could make out that this is a case of generalized pustular psoriasis of annular variety. And it was soon biopsied and confirmed, the diagnosis was confirmed. This child also was not allowed to go to school for nearly 1 year. And I started the child on cyclosporine, 5 milligram per kg per day, the same dosage. And after 12 weeks, you see there was complete clearance of the lesions. His parents were so happy. And you look at the abdomen, if you see, the child has a Cushingoid appearance by and large, and you can see the striae over the abdomen because of long-term steroid. And the pediatric nephrologist friend of mine was extremely happy because she could also bring down the steroid faster when cyclosporine was added, because her idea was to bring down the steroid to 0 as early as possible. So cyclosporine helped not only in generalized pustular psoriasis, but also in the basic disease of the child. In atopic dermatitis, cyclosporine I give, more or less for severe, moderately severe to severe disease, 5 milligram per kg per day, or sometimes if the child is low body weight, 4 milligram, and 1 milligram per kg every 3 to 4 weeks, I gradually reduce. Often what I do, the disease is so severe, I had to recourse to oral steroid and cyclosporine for initial 2 to 3 weeks, then stop steroid gradually and continue cyclosporine. This is a severe atopic dermatitis in a 4-year-old boy for 8 to 9 months, where I didn't have any other option rather than giving cyclosporine, but slightly lower doses. Let me tell you, friends, cyclosporine dose requirement in psoriasis is a bit higher than atopic dermatitis. That is my experience in pediatric age group. So 4 milligram per kg per day after 8 weeks, there was, huge response, I must say. So now come to the story of an adult patient, a 40-year-old lady who had psoriasis for 10 years. And this lady was brought to my clinic in an ambulance. And when I examined her in the ambulance itself, I found that she has generalized pustular psoriasis. The history was for more than 3 months. Her general condition was very poor. She had hepatorenal involvement. This all we came to know after she was admitted. I shall be sharing with you soon. She had very high serum calcium level, severe respiratory distress, septicemia, and electrolyte imbalance. So she was admitted in the hospital, and you can see that there is a central venous catheter because her veins actually were not palpable in the peripheral extremity. She was going into septicemic shock. So a team of doctors, composed of internists, critical care experts, infectious disease experts, all came into, her rescue together along with me. Most importantly, she received multiple antibiotics, intravenous antibiotics, at least 2, along with, cyclosporine, which she was earlier given in a smaller dose. I gave a proper dose of cyclosporine. Look at the, lakes of pus of generalized pustular psoriasis over her skin. And looking at the, the leg, you don't have any difficulty in understanding how much anasarca she had developed by this time. So she received subsequently many other drugs like methotrexate, like biologics, but one consistent single medicine she was on and off was cyclosporine. That continued for a number of years. And, subsequently, she came out of her disease and her entire family was extremely happy. They didn't expect her to survive, actually. So this is the story of a 36-year-old female, a school teacher, who had plantar psoriasis for 10 years. She was unable to walk for at least 1 year, unable to go to school, and was off school for literally 8 months. She had developed severe depression when I visited her. And she had suicidal, ideation at least on 2 occasions. A very frustrated, depressed lady because of souls like this. Already methotrexate, oral retinoids have been tried, but not much with success. When I got this history that she is a cyclosporine naive case, I thought that she might respond to cyclosporine. I put her on cyclosporine. And it completely cleared in just 10 months of time. She could walk and she gained back her confidence. That was the most important thing. Another important thing in her life was she was off antidepressive medicines. Gradually, though. She resumed her school. Her post-treatment follow-up for 6 years was uneventful. Now, when we give cyclosporine, friends, we have to, monitor these patients properly, like CBC, ESR, liver function test, serum lipid profile. This is another thing which we have to keep in mind, that lipid profile abnormality is not a monopoly of oral retinoids. It can occur with cyclosporine, and often it occurs. Serum electrolytes, it is, blown out of proportion, actually. If you judiciously select the case, properly monitor the patient, and give a proper dose, depending on the disease, and the patient's compliance is good, nothing really happens. Electrolyte imbalance practically does not happen with the dose which we give. Please do remember the dose which our pediatric nephrologist, hemato-oncologist, rheumatologist, they give at least 4 times the dose what we give to our patients. X-ray only in selected cases, not in all cases. When there is a strong personal history of earlier tuberculosis or family history of tuberculosis, so there is a contact history, then only you do X-ray checks. But checking of the blood pressure at regular intervals, 7 to 10 days, is very, very important. Routinely, apart from CBC, creatinine, electrolytes, and lipid profiles are checked initially And if you find that the lipid profile is abnormal, then only repeat it after some time. Otherwise, there is no need of in every visit repeating the lipid profile. You just do CBC and just do creatinine if it's a elderly person. In children, I don't repeat creatinine because I have hardly seen any creatinine abnormality in children. But CBC, yes, and you have to look specifically at WBC count and platelet count, apart from hemoglobin, of course. So there are 4 issues. Optimizing the dosing of cyclosporine is not yet established. Pharmacokinetic of cyclosporine in children are different. We have to remember, we can discuss at length during the panel discussion. Reduction of the dose should be gradual, not abrupt. However, for all this, there is not much enough evidence. That is one thing where we have to work. So basically, the decision making for giving cyclosporine depends on benefits versus risk, and definitely cost is an important factor. Preparation of cyclosporine, it comes in 100 milligram capsule, 50 milligram capsule, 25 milligram capsule, and solution 100 milligram per ml. Friends, please do remember that unlike other pediatric suspension, which comes 5 to 10 milligram per 5 ml or 1 ml, this is the one which has got maximum concentration of the drug. In 1 ml, it contains 100 milligrams. So one has to be extremely careful while prescribing cyclosporine. And there is a cyclosporine syringe provided with the suspension. You can, if for small children, orange or apple juice can be given to mask the taste, but you should avoid grapefruit juice. I have seen many of our junior colleagues have got a misconcept about grapefruit juice and grapefruits. These are not same. I mean grapes. These are not same. Grapefruit is a hybrid of sweet orange and pomelo. So if you look at the cyclosporine syringe, you see it is 0.5 milligrams. So what if you are giving to a very small baby, which I have given, to 3-4 month old baby, I had to give extensive psoriasis from head to toe. I had no other option. So what if the child needs only 0.25 milligram? There is no option in cyclosporine syringe. And that's why we suggested that insulin syringe, in which 1 ml is divided into 40 equal units. This 40 units, 1 unit is 2.5 milligram of cyclosporine. So insulin syringe, to our mind, is much useful, particularly when you are giving cyclosporine to a very small baby. We have given cyclosporine to alopecia totalis to a great extent of success. You can see this particular girl who is growing hairs on a scalp of alopecia totalis. This is the collection of 17 patients which are under publication now. And this was accepted as an oral presentation in recently ended World Congress of Dermatology in Singapore only in last month. So this is the 8-year-old girl with alopecia totalis for 2 years. Look, after gradually introduction of cyclosporine, how the hairs are growing. And I'm very happy to share, friends, that after stoppage of cyclosporine for nearly 5 years, 4 years, the child retains the hair completely. There hardly has been any requirement of further cyclosporine. In between, she used to develop small patches, which used to be, controlled by topical mometasone solution. However, it is not the, story of success always. Here there is a child in which we could grow some hair, but in the process, the child developed gum hypertrophy and we had to stop it. Lichen planus is a condition where rapidly spreading lichen planus can be nicely controlled with cyclosporine. Additionally, something which is a stigma for lichen planus in type 4 and type 5 skin of color is the post-inflammatory hyperpigmentation. And our observation is that when the child is treated with cyclosporine, this post-inflammatory hyperpigmentation also disappears, which does not disappear with any other form of treatment. There are adverse effects of cyclosporine like hypertension in adults as well as in children, hypertrichosis, which is almost universal, I must say. If you continue cyclosporine beyond 4 to 6 months, but let me tell you very clearly, friends, when you stop cyclosporine, you give cyclosporine holidays for 6 months, you give rotational cyclosporine, then in between, this hypertrichosis gradually resolves on its own by more than 80 to 90%. Gum hyperplasia by and large occurs in adults, but you have seen a small child also developing gum hyperplasia. As I have told you earlier, there is no electrolyte and renal abnormality. These are the things which are blown out of proportion. Hyperlipidemia, yes, I have seen many. To develop hyperlipidemia, that has not been a major threat. Never needed any lipid-lowering agent for the hyperlipidemia. Only cyclosporine was temporarily stopped or the dose was reduced. Hyperlipidemia was also under control on its own. This is the hypertrichosis. As we can see here, this particular boy on the right-hand side had extensive atopic dermatitis. The atopic dermatitis disappeared, but hypertrichosis developed, but that also resolved with time during cyclosporine holidays. This boy I was referring to. So gum hypertrophy, if you see that, I'll show you two pictures. They develop more when cyclosporine is self-abused or self-medicated by the patients without doctor's advice. This particular gentleman had extensive psoriasis all over the body, to the extent that when he met me first time, he said, "Doctor, I have not been able to see my own body in the mirror for more than 6 years." And I put him on cyclosporine, and after 6 months, he came very happily with a box of sweets. The doctor, my body has entirely cleared. I can see my body, I can do exercise, and nobody stares at me. But what happened after that, he continued taking cyclosporine, and after maybe 7, 8 years, one fine morning, he landed up in my clinic saying, "Doctor, I am having some peculiar feeling inside the mouth, as if some tumor has grown inside the mouth." I asked him to open his mouth and found that he has gum hypertrophy. Then I asked him, "What you are doing all these days, about your psoriasis, how did it behave?" He said very casually, "It used to come, he used to take that magic medicine. That magic medicine means cyclosporine." That means he self-abused cyclosporine, and as a result, he developed gum hypertrophy. Another thing you must take note of is the poor orodental hygiene. So this is very important, friend. So this is the close-up look at the orodental hygiene. So whomsoever you are putting on cyclosporine, this is I have learned from our oncologist colleagues that betadine or antiseptic mouthwash regularly is a must, at least 3 to 4 times a day. Are there any cases of cyclosporine failure or resistance? Yes, peptidyl prolyl isomerase is a gene on chromosome number 7, which sequesters calcineurin and binds the cyclophilin, the protein, with cyclosporine. The mutation of this gene can lead to lack of efficacy of cyclosporine. So there is a subset of patients in atopic dermatitis, in psoriasis, who are less likely to respond to cyclosporine. And we have to come to know about this particular phenomena gradually over a period of time. If there are faulty case selection and monitoring at the beginning, use of subtherapeutic doses of cyclosporine, which I often find, unfortunately, many of our colleagues do. Drug interactions, cyclosporine had got a lot of drug interaction, including a very common antifungal itraconazole. There are many, in fact, one has to keep in mind when giving cyclosporine to an adult patient. The same question does not arise in a child, because child is unlikely to be on multiple drugs for long-term purpose, and if there is a poor compliance. So, friend, I have come to the end of my presentation. The take-home message is, after steroid, cyclosporine is the most useful, prompt in action, consistent, and safe immunosuppressive drug discovered so far. Its beauty of cyclosporine is its consistency. It works with maximum consistency among all the immunosuppressive, I must tell. It is useful in a wide range of difficult to treat chronic dermatosis in pediatric age group. When judiciously used with proper indication, dosage, monitoring, and compliance of patients, it is very safe. Don't use homeopathic dose of cyclosporine, it does not work. And its only limitation is its cost. That is what I believe, by and large. Thank you very much for your patient hearing. This is our Institute of Child Health. So now it is my privilege and pleasure to invite Professor Dr. Carsten Flohr to start his deliberation. Carsten, please.
Yeah, thank you very much, Sandipan. Hello from London to India. Delighted to join you once more for this webinar. Can you see that?
Yes, we can see that very clear.
Yeah, so you've asked me to talk about the TREAT trial, which has been my baby and the baby of many dermatologists across the UK and Ireland for, well, almost 7 years. It's been a very long journey. This is an investigator-led study funded by the UK Department of Health, the National Institute for Health and Care Research. So it's not a study that was funded by the pharmaceutical industry and was a big beast to lift. But finally, the lifting is over and the trial will actually appear in the British Journal of Dermatology over the next few days. So this is hot off the press. You're one of the first to hear the results. So using cyclosporine and methotrexate as first-line systemics for severe pediatric atopic dermatitis, lessons from the TREAT trial. The situation is quite depressing when it comes to randomized controlled trial evidence on conventional systemic medication in pediatric patients with atopic dermatitis. There is, or has been until now, no adequately powered randomized controlled trial, but the TREAT trial is changing that. So until now, we've not really had a gold standard, at least not officially. I mean, it was interesting to hear, Sandipan, clearly cyclosporine is a drug that is commonly used in your parts of the world. Certainly many regulatory bodies, I'm not sure about your setting, require first-line conventional systemic treatments before you can travel into a novel agent like loperamab or a JAK inhibitor. Cyclosporine is licensed only from 16 years of age, and as you just said, comes at a relatively high cost. So with that in mind, and that cyclosporine is the only licensed treatment, which drug would you compare it with in a randomized controlled trial that wants to set the gold standard for patients with atopic dermatitis? And at what dose would you want to compare these two drugs against each other? Well, to find answers to all of these pertinent questions, we ran a survey many years ago now, 2013, collected data on the current practice in the management of severe childhood atopic dermatitis across Europe. And we were very clear in our survey that we wanted this answer to be about what would you use and at what dose to induce long-term disease control outside of the context of acute flares. We wanted to identify barriers to the use of specific agents, and then to inform the design of a clinically relevant intervention study that would potentially change practice. We used this case scenario of a 12-year-old who was maximally treated topically and had failed to respond to narrowband UVB phototherapy as a scenario to standardize the responses from our colleagues. 340 odd consultants from 8 European countries took part. 71% used systemic medication in severe cases. Cyclosporine clearly was the first-line therapy at that stage, with 43%, followed by, and this is really interesting, oral corticosteroids. Most guidelines strongly advise against the use of oral corticosteroids as long-term treatments for a disease like atopic dermatitis, but still about a third of all colleagues said that they were using that first line, 22% using azathioprine at that stage. This is a drug that we tend not to use anymore in Europe because of the perceived risk of malignancy, especially if you use azathioprine for longer than a year. And then methotrexate was an emerging second-line treatment, 12%, and 42% used at third line. That picture, I hasten to add, has hugely changed over the years since that survey in 2013, and methotrexate is now our first-line systemic therapy, certainly in a UK setting in adults and children. But let's come back to our RCT to really nail that properly in an evidence-based fashion. So we decided, based on these results, to compare cyclosporine with methotrexate. And these are the doses that we went for. So you gather from the presentation we've just heard that you would tend to use slightly higher doses. These were the average doses that the European colleagues were using: 4 milligrams per kilogram per day of cyclosporine and 2 divided doses of methotrexate, 0.4 milligram per kilogram per week of methotrexate. This meant that quite a few patients ended up on 25 milligrams per week of methotrexate, which was our maximum dose for this trial. Children aged 2 to 16 were eligible to take part. We were keen to test the drugs both on therapy, but also to have follow-up for another 6 months to see how the disease severity would fare after that. We were going to work across the UK and Ireland and look at drug efficacy and safety, quality of life. There's a detailed cost-effectiveness analysis in this trial because of the higher cost of cyclosporine versus methotrexate, but I'm not going to cover that today. And we have a very detailed mechanistic component in the trial. We're, for instance, looking at cytokine profiles. We've used tape strips for that. We've also got systemic immunological readouts and a few other investigations, such as very detailed renal tubular biomarkers, which again, I'm not going to cover today. So 13 sites across the UK and Ireland. You can see them on the right-hand side, a nice geographical spread across the country. All paediatric hospitals were part of the trial. Alan Irvine from Dublin supported me in leading the study. And some of the other investigators there may be familiar to you by name. And these are our two key hypotheses. So first of all, that cyclosporine is fast at reducing disease severity at 12 weeks into treatment. But then secondly, and this is important, that methotrexate leads to better disease control off therapy, measured as a reduced risk of reflaring. So either restarting systemic therapy or returning to baseline disease severity. That's a very high bar, and we can come to that later. And patient-reported flares as well. Primary objectives are to assess the change in disease severity using the objective score between baseline and 12 weeks of treatment, and second, to examine disease remission. So that's the time to the first significant flare after treatment cessation. And then as secondary objectives, the disease severity mapped over the whole course of the trial using the EASI, the OSCORA, the Investigator Global Assessment and POEM scores, the proportion of children who reflared after treatment cessation, the impact on quality of life measured through CDL-QI scores, and then study treatment safety as well. This is the flow chart for the trial. So we randomized 103 children. We had estimated in the power calculation that we needed 102 children, 51 in each group. We ended up having 52 in the cyclosporine compared to 51 in the methotrexate group. One lost to follow-up in the cyclosporine group, 4 withdrew, and there were 7 premature discontinuation of treatment in the cyclosporine group, corresponding to 1 loss to follow-up in the methotrexate, 5 withdrawals, and 13 premature discontinuation of treatment in the methotrexate group. Of course, the intention to treat analysis, which is what I'm presenting, included everyone who was randomized to treatment. This is a very pragmatic design study. There's no placebo. In fact, we thought this would be dangerous given that one drug is given twice a day and the other one once a week. Everybody had to have an objective score of at least 30. And concomitant topical anti-inflammatory treatment, either with topical corticosteroids or calcineurin inhibitors, was allowed. The severity assessments, even if we didn't have a placebo, were blinded. So people did the severity assessments across all 13 sites who were not involved in the trial otherwise. Here, the baseline characteristics, and there was this overall well balanced through randomization, looking at sex, ethnicity, age, BMI, EASI, objective score, and POEM scores, as well as the CDL-QI. So what did we find? And in case you wonder where this is London at New Year's Eve. It's the London Eye here. St. Thomas's Hospital, where I work, is on the right-hand side. So we found what we expected, that cyclosporine is faster at reducing the disease severity at 12 weeks. So this is a more than 5.69 higher reduction in the objective scoreard index at 12 weeks in the cyclosporine compared to the methotrexate group at a level that's statistically significant. The second core primary outcome was statistically not significant, but the trend was that cyclosporine showed a higher risk of returning to the baseline objective scored or restarting systemic therapy during the 24 weeks after the treatment was stopped. You can see the hazard ratio here, 1.55, so 55% higher risk of reaching that level in the cyclosporine compared to a methotrexate group, but statistically not significant. This is a very high bar that we were setting there, looking, back at the trial. Now, looking at the picture over time, continuously, if you like, using the EASY score, so looking at the changes from baseline here all the way to 60 weeks. Statistically significant results are marked with the stars. Children were on treatment for 9 months. Cyclosporine here in blue, you can see is fast and reducing the EASY score. But interestingly, methotrexate, red dotted line, improves, catches up, is as overtaking cyclosporine at 20 weeks. And then this is also quite interesting. There's a continued improvement down to 9 months when we stopped therapy. We had to be pragmatic with this trial. We had to stop at some stage because obviously the longer a trial goes on, the more cost consuming and staff intense this study is. But one wonders what would happen to this graph if we continued therapy at that stage. So we stopped the 2 drugs here, and you can see that those on cyclosporine move up further than those with methotrexate, so better disease control there at a level that is statistically significant. And you can see the differences in the EASY score in the 2 groups at these time points down at the bottom here. Very similar picture with the objective scoreard over time. Investigator global assessment, the same. That's obviously not, so it's a score that has a lot of width. It only goes up to 5 points from being clear, 0 to very severe 5. So that is why the graph is a bit flatter there. POEM, again, the same trends. So cyclosporine significantly better than methotrexate at 12 weeks, with a POEM of almost 3, better than cyclosporine. And then at the last follow-up point, week 60, it's the other way around. Methotrexate is better than cyclosporine. It was good to see that both drugs led to a significant improvement in quality of life above the minimal clinically important difference, the MCID, which for the POEM is 6. So both were down by about 8 points. And then also good to see that after stopping therapy at 36 weeks, the quality of life reduction was more or less sustained there in both groups. Although we didn't see a statistically significantly higher risk of returning to baseline severity or having to restart systemic therapy, the number of parent-reported flares in the cyclosporine arm was higher than in the methotrexate arm after treatment cessation, with a difference in mean total number of flares of 3.22. I'm only showing you the EASY 75 values, so the 75 reduction values in the EASY score from baseline at 12 weeks, 36 weeks, 48 weeks, and 60 weeks. But the results were very similar for EASY 50 and EASY 90. So you can see that almost 45% of cyclosporine patients reached an EASY 75 at 12 weeks compared to just about 20% in the methotrexate They were very even at 36 weeks, and then methotrexate statistically significantly superior, again identified here with a red star. This one was also statistically significant. Methotrexate superior to cyclosporine using the EZ75. Treatment safety was overall reassuring. So methotrexate, as you'll be aware, can cause nausea. Over 40% of our patients had nausea. That compared with 17.6% for cyclosporine. There were no significant blood or blood pressure abnormalities in either group. This was a heavily monitored trial imposed by the Research Ethics Committee that reviewed the application. Low rates of withdrawal and non-compliance in the trial, and no safety concerns raised by the Independent Oversight Committee either. And there were no suspected unexpected serious adverse reactions. So in summary, cyclosporine is superior to methotrexate in reducing disease severity at 12 weeks. But the difference that we saw, close to 6, is below the minimal clinically important difference, even if it was statistically significant, but that's using cyclosporine at the 4 mg/kg dose, rather than, for instance, 5 mg/kg or higher, as you might be using in India. Methotrexate led to better objective disease control over time off therapy. There was a significantly higher number of parent-reported flares of therapy in the cyclosporine compared to the methotrexate group. Both drugs led to noticeable improvement in patient-reported quality of life, which was sustained after stopping the medication, and then both drugs were reasonably well controlled, and overall reassuring safety profiles seen, which is good considering, certainly in our setting, there's a lot of concern from parents about such medications. Coming to the costs, so cyclosporine is more expensive than methotrexate, much more so. These are the UK prices, but 0.55 pounds per week for methotrexate compared to almost 25 pounds per week for cyclosporine. So methotrexate is now our first-line conventional systemic choice for children with severe atopic dermatitis, partly based on the TREAT trial. We did test doses in everyone. So we did a 1 mg/kg test dose in all children entering the methotrexate arm. There were no idiosyncratic reactions. So our suggestion is you can go straight to the full treatment dose of 0.4 mg/kg per week. And the blood safety measurement frequency can be rationalized, given that we didn't really have any concerning blood profiles on, for instance, full blood count, renal and liver function testing. And we used very sensitive renal function biomarkers. That's a paper that is separately in the pipeline. Absolutely no concerns there in the cyclosporine arm, where you would expect more renal function abnormalities compared to methotrexate. So that was very reassuring. 2, I would suggest patients on these medications can be seen at 4 weeks and then probably 3 monthly thereafter if they're doing well and there are no signals on safety bloods. I'd like to close by thanking all the investigators involved in the trial. This was, as I said, was a huge undertaking. As an investigator-led rather than pharma-sponsored study. We had a trial nephrologist, for instance, in fact, 2 over time, who very carefully reviewed all renal profiles. We worked with the clinical trials unit, specializing in pediatric trials at Liverpool University. Our trial steering committee members, including the patients who were on these steering committees. We were supported by the UK Dermatology Clinical Trials Network, and the Translational Dermatology Research Network, UK Trends. All investigators in the study sites and their research nurses and clinical trial practitioners. And as I said, the results are in press with the British Journal of Dermatology and should come out over the next few days. Thank you very much.
Thank you very much, Carsten, for your extremely nice and thought-provoking presentation. I think we can have during panel discussion this particular aspect of methotrexate coming up, instead of cyclosporine more. This is a very interesting observation. we have discussed in International Eczema Council also. And Professor Carsten Flohr is not only the pioneer of atopic dermatitis globally, he's a pioneer for many therapies also. And today it's our honor to have him on board. Thank you very much, Carsten. And here I request, Dr. Sushil Taliani as a moderator to start the moderation for the panel discussion. Dr. Sanjeev Kandari, Dr. Sachin Verma, and Dr. Abhijit Shah to join. Over to you, Sushil.
Thank you. And that was very interesting and very illuminating talks, both by Professor Sandeepan and Professor Carsten Flohr. And with whatever information we have had, I'd like to share my slides and start the questions rolling.
Yeah.
So we all know that, as we heard, cyclosporine has been approved way back in 1997 for treatment of psoriasis. And National Psoriatic Foundation also recommends that be used for erythrodermic and pustular psoriasis. British Association of Dermatology recommends cyclosporine in the patients with chronic idiopathic or chronic spontaneous urticaria that are refractory to corticosteroids, though we have a different approach. And IACI, Gallon, EDF, WHO guidelines recommend cyclosporine in patients with severe chronic spontaneous urticaria, which are refractory to 4 times the dose of second-generation antihistamines, standard dose. American Academy also recommends cyclosporine for patients with atopic dermatitis refractory to topical treatment. And consensus-based European guidelines recommend cyclosporine for patients with atopic dermatitis who require systemic immunosuppressive agents. All this, of course, in people who are immunocompetent. So these are few of the approvals that I came across. And as we saw, actually the disease that we treat with similar etiopathogenesis and which are likely to respond, off-label, we use it in many conditions. So that's what we're going to discuss here. And we are also going to learn from a panelist about how they select the cases. We heard Dr. Sandeepan, but we'll hear from others also, dose that they prefer, the duration, how they monitor. So why cyclosporine when there are corticosteroids and immunosuppressants like azathioprine, cyclophosphamide, mycophenolate, mofetil? Where do you use in dermatology cyclosporine is the most preferred molecule? I could start with all of you one by one, please, in any order. Starting with Sandeepan, since I'm sure, and then whoever wants to chip in later. Clear.
Thank you, Sushil. I think I have mentioned that during my presentation. Even today, after use of cyclosporine and other immunosuppressives for more than 2 decades, I personally believe that cyclosporine is not only efficacious, its efficacy is most consistent. Yes, of course, methotrexate, is also quite effective. Its cost is also less. Cyclosporine cost is higher. And the important trial which, Carsten Flohr and colleagues, carried out, that sends us a message that, look, cyclosporine, methotrexate, both are very safe. And in fact, methotrexate has an edge as far as some parameters are concerned. But as of now, to control severity of a disease, chronic disease, which jeopardizes the quality of life of a child as well as adult, to bring down the disease fast, effectively, and safely, there is no other alternative than cyclosporine. And biologic is beyond the reach of the common people.
So got you. So wherever we need rapidity of action, we think of cyclosporine.
Yes.
But in your presentation, you showed about 15 indications and more, but there was no mention of drug rash. We do use cyclosporine in severe drug rashes also.
Yes.
So do you use in pediatric age group? Yes or no?
Yes. I think the current recommendation for managing Stevens-Johnson syndrome and toxic epidermal necrolysis instead of steroid and IVIG, cyclosporine is much more effective, consistent, and safe.
Professor Carsten, do you have anything more to add?
Yes, it's interesting. To hear the enthusiasm about cyclosporin. I'm N equals 1 here, but I think there's slightly less enthusiasm for the drug in the UK. Not just in the atopic dermatitis context. As I said, if you think about the other drugs here on your list, azathioprine, I mentioned the significant risk of malignancy, especially lymphoma, if you use it for longer than around a year. Cyclophosphamide, I have not used in children at all, and mycophenolate mofetil is, in terms of the evidence base for that as a treatment, doesn't go beyond individual case reports and case series for most indications. So that would be my concern there. I have, in the area before omalizumab, I did have the occasional patient where I used mycophenolate, for instance, for chronic spontaneous urticaria, and it did seem to help in some cases. I don't use it for atopic dermatitis anymore. Luckily, we only have to travel through one conventional systemic drug these days, and can then go into biologic or small molecule. So that's why this and the other drugs have sort of fallen off the cliff a little bit. But so I agree with regard to cyclosporin and speed of onset. Of course, if you're in a desperate situation, you would go for cyclosporin, and then you can switch. And I think Sandipan mentioned that as well. Switch to methotrexate after that. Maybe 3 months of cyclosporin, gain control first, and then switch is certainly something that we sometimes do in our practice.
Dr. Sanjeev Kandari, please.
Yeah, thank you. I agree with most of the things which are said and differ at a few places also. First place where I differ is I don't use 5 milligrams per kg body weight because one of the side effects which I encounter in my practice is GIT upsets, which are fairly common with cyclosporin. And also, Sandeepan mentioned that no renal abnormalities, it's a myth. In spite of a higher dose which is used, is difficult for me because I do see them in my practice. And I was very happy to hear Dr. Carsten's talk that methotrexate is proving to be a good drug because it will cut down the cost, and over a period of time, it will become, and our experience with methotrexate is very good. But all said and done, I still use cyclosporin as a rescue therapy for about 3 to 4 months in the initial phase. My usual dose is between 3 to 4 milligrams. I usually don't use 5 milligrams per kg body weights. And of course, I found it very, very useful in chronic spontaneous urticaria. And sometimes where omalizumab is becoming a problem, then I combine it with omalizumab and then give it. That also is an additional advantage. I found it very useful in prurigo, lichen planus, where I use it very, very often. And there was an interesting thing which Sandeepan had mentioned about the pigmentation. I haven't really observed that very much in adults, but maybe in children I would tend to agree. But I can even recall sitting right here talking, there are many children who've gone on with their pigmentation in spite of giving them cyclosporin almost over a year's time now.
Dr. Sachin.
I think first I would like to compliment Dr. Sandeepan for that wonderful lecture, and more interestingly, Dr. Carsten. I think the talk on methotrexate in atopic dermatitis is very enlightening. We don't normally use methotrexate so commonly in atopic dermatitis. We use in psoriasis more commonly here. And methotrexate being used over 9 months in atopic dermatitis is actually very encouraging. We have not seen many prescriptions being used that here. But that's very, very encouraging. I would like to see if a similar study can be done on psoriasis and see in long term what happens, which we know that, is the flare reduced with methotrexate in psoriasis as well. And I think it'll be very interesting to observe that. More importantly, why do I choose cyclosporin? I think I choose cyclosporin for faster action. Where I want an action very, very quickly, I think that is the time I'm going to choose cyclosporin over other drugs. Azathioprine is not much used these days for its own risk. And the other, over the other drugs, I think the bone marrow suppression is reasonably low with cyclosporine. That is an advantage. So these two advantages, reasonably safe in terms of faster action and less bone marrow suppression. And it can be, the only problem with cyclosporine is that you can get on the train, you don't know how to get off it. So once you are on cyclosporine on long-term basis, even in atopic dermatitis, even in eczemas, in alopecia totalis, when you take off cyclosporine, the disease tends to recur back, and that is what exactly Dr. Carsten showed. It's a very promising drug, but as a rescue therapy. And I agree with Dr. Sanjeev Kandari that I use in the dose of up to 4 milligram. 5 milligram is a little high for me. I only go in rare areas, but about 3 to 4 milligram is what I use.
Okay.
So this is my view on that.
Dr. Abhijit, any additional points?
Yes, sir. I couldn't agree more. Actually, it's all about the balance between the experience and evidence. So probably all of us are more experienced about cyclosporine and methotrexate. Definitely as a stress buster, rapid control of the disease to improve quality of life faster. As Dr. Sachin correctly mentioned, low chance of hematopoietic toxicity, and obviously it's not a teratogenic drug. That also we should keep in mind. So these are the probably a few of those advantages of cyclosporine. That's all. And one thing I just want to add. I just want to echo Dr. Kandari. In few patients, definitely, I also experienced abdominal pain. In those cases, I have to reduce down the dose from 5 to 4 or 3.5. It happens. Definitely, I also have experienced in some of the patients.
I would agree. And actually, Dr. Sanjeev, and it is believed that it may cause hypomagnesemia. And one of the symptoms of hypomagnesemia is GI symptoms. So I normally give them a magnesium supplement also, and that has reduced the risk of GI disturbances in my patients.
Sir, may I come in for this?
Yes.
Yeah. Actually, regarding hypomagnesemia, I have learned, I've heard from some of the consultant few years back in some of the conferences. So from then, for last one and a half year, I started doing serum magnesium baseline, and again, I used to repeat them after a few months. But in all of the cases, I found them absolutely normal, whether it is baseline or it's a follow-up magnesium level. So I probably do not agree with this fact that hypomagnesemia commonly occurs with the dose of cyclosporine or duration of the we use for what we use for this molecule.
Yeah, I find, if you give something like enterogermina, it really helps in these patients. Magnesium is useful if you get paresthesia with cyclosporine or something like a neurological symptom. That's where magnesium has been said that it is responsible, but not so much
on.
Yeah,
true.
And not so much in the GI.
I've not seen in any cases, sir.
Dr. Sushil, Dr. Carsten wants to, chip in. Yeah.
Yes, please.
Thank you. Just a point on the perceived, if you like, disease modification through methotrexate in the TREAT trial. I mean, you saw that reduced risk of reflaring in that group compared to the cyclosporine group. I didn't show you the tape strip immune profile readouts, but one of the things that we found is that in the methotrexate group, there's a significantly higher expression of natural moisturizing factor in the skin barrier in the methotrexate group compared to the cyclosporine group, which, I mean, as you know, is essentially, I mean, it reflects to a degree at least filaggrin breakdown products, and so that would be a potential explanation. Methotrexate, has that ability, why we saw better disease control even off therapy after the 9-month on treatment.
So it's interesting to know that along with its effect on the immune system, it works on the barrier function also.
Yeah.
So label indications, unfortunately, a few that we discussed. Now, many times when we look at the psoriasis, we don't look at just the area of involvement or PASI scores. We also look at the dermatology life quality index, its impact on the patient's health. So many times we tend to give a more potent medicine for palmoplantar psoriasis, nail psoriasis, scalp psoriasis, or genital psoriasis, for example. So would you think of these as some of the indications, as Dr. Sandeep has already shown one of the patients where he used it for palmoplantar psoriasis and where he had a 6 years follow-up. I would like to know from you, Sandeepan, in that patient, after you withdrew cyclosporine, I'm sure you must have given some maintenance treatment.
Right. So this is a very interesting question, Sushil, you have asked. Let me tell all of you that this particular patient or this type of patients of palmoplantar psoriasis, my first line of treatment is, methotrexate. It has been methotrexate for more than 2 decades, and we always get good results. Once these retinoids came, we started using, etretinate for these patients and got good result. This particular patient did not respond to either methotrexate or etretinate to adequate response was there. So that's why out of no choice, I had to use cyclosporine, and I found extremely good result. So this is not a routine use of cyclosporine. So for palmoplantar hyperkeratotic, lesions kind of thing, fissuring or psoriasis, actually cyclosporine is not the first line of treatment. So, but just I wanted to show that the, versatility of cyclosporine, when other drugs don't work, then cyclosporine work in odd situations. That is the versatility of cyclosporine.
So
And I totally agree with Carsten that we have seen with steroid tapering, the flare of the disease, whether atopic dermatitis or other, is very fast. With cyclosporine, also it occurs after stoppage, but it is slower. But with our experience of using methotrexate in psoriasis, we have seen there is, after stoppage of methotrexate, there is long-term remission of the disease. So this can be extrapolated to his tree trial in atopic dermatitis. I fully agree with his observation. This is a wonderful.
So after 8 or 9 months of cyclosporine, there was no sequential drug in your patient.
No, this lady is very fortunate, and as well as I was also very fortunate. Just moisturizations, just advise that whenever you see some fissuring or cracking, use a potent steroid for 2 to 3 weeks. And that is how we could manage without giving any, other medicines.
So I would like to ask the other panelists as to whether they've used it for any localized psoriasis with high impact on quality of life, a molecule that is cyclosporine. I'm talking with Indian context where biologics are not that easily available and it's out of pocket for patient.
Can I make a comment, Sushil?
Yes, Sanjeev.
In palmoplantar, what I've found is that acitretin is a good choice for thick palmoplantar psoriasis. And very good choice in palmoplantar psoriasis is cyclosporine if it is vesicular or pustular in nature. And I am replacing that with JAK inhibitors now, which is proving to be excellent drug if it is a pustular form of psoriasis on the hands and feet. It's proving to be a much better drug than even cyclosporine or methotrexate or acitretin. Those patients who are not responding, they respond very well to JAK inhibitors in this palmoplantar psoriasis.
Thank you. Dr. Sachin and Dr. Abhijit, what do you think of apremilast in some of these situations?
So the problem with apremilast is, one is it's very slow acting. That is one aspect about apremilast. The second is the acute side effects. While giving apremilast, a lot of people don't tolerate it that well. They have nausea, vomiting, headache as you step up the dose. The third problem is the consistency is not there. You cannot predict whether apremilast will work in which patient. So in my view, apremilast is a great drug for people for maintenance, but it cannot be a drug when you want to reduce your disease very quickly or rapidly, and you can't predict its outcome. I cannot say with like with cyclosporine, I can say with consistency that okay, in 6 weeks, 8 weeks time, I'm sure your disease will come down. With drugs like apremilast, even with with tofacitinib now, I can actually do that. I think with various JAK inhibitors, I'm very happy with addition of JAK inhibitors being available in India and now being affordable. I think we can say with some consistency, though I would still rate cyclosporine in acute stress buster over a JAK inhibitor. But with apremilast, I'm not too sure of that. And therefore, apremilast I give in
Right.
patients
We got your point.
Yes.
Dr. Vijay, do you have any comments?
Yeah, I'm second in opinion with Dr. Sachin regarding apremilast, nothing to add. But regarding cyclosporine, I have used cyclosporine in good number of cases with palmoplantar psoriasis, especially when they are approaching any important life event like a wedding and important exam like this. Obviously, in pustular psoriasis kind of thing, it's a better choice. But even in chronic type of psoriasis, palmoplantar psoriasis, it also works very well. And second question is regarding maintenance. Again, it is a very patient tailor-made approach. Some patients do not require any further systemic disease like methotrexate for maintenance. Only you can maintain with moisturizer and weekend topical steroid kind of thing. And obviously, few patients are there who always tend to relapse. Then you need to maintain them with low-dose methotrexate and other supportive measures. I have not used in nail psoriasis per se.
So in short, we all agree that it's a crisis buster situation, right? Where you use, and when others have failed. Now, using the same knowledge, in atopic dermatitis also, we don't always look at the SCORAD and EASY scores. Would you consider, in view of morphological or clinical presentation, even a person with more localized version of atopic dermatitis, use of cyclosporine? You start with Abhijit since he's on the mic. So,
yeah,
would you sometimes use this in more localized but more symptomatic?
Yes, you are absolutely right, sir. In a busy OPD setting, it's not practically possible to calculate EASY or SCORAD. Obviously, those apps are available. If you want to, you can do it within 30 seconds. But we usually do not do this SCORAD. We just make a rough eye estimation regarding the severity, scaling, inflammation, and thickness of the scale. Obviously, according to the standard textbook teaching, severity of the disease is one of the main indication of use of cyclosporine. But there are certain situations where, again, I must say that approach should always be patient tailor-made. According to the situation, you have to decide. Certain situations, for example, a very disturbing and devastating kind of facial eczema, which keeps on which make the patient and the parents very much anxious. So in that case, if you want to give them a first control, even though it is localized kind of rash, then you have to give cyclosporine. So these are the few situations where you need to adjust according to the situation and deviate from the so-called textbook teaching.
Dr. Sandeepan?
By and large, we find that, cyclosporine is quite effective in such situations. But I was coming to actually raise my hand for, chipping in for another interesting point you have raised. Nail psoriasis. We are lucky not to see much of nail psoriasis in pediatric age group, but whenever we see nail psoriasis even in adults, involvement of the nails, particularly multiple nails, dystrophic nails, is suggestive of a terminal interphalangeal joint arthritis, and for which instead of cyclosporine, it is methotrexate or one of the JAK inhibitors like tofacitinib is always better, to be used actually. So I have got very good result with that. I am sure that all of us have got the very good result with that.
I often use methotrexate for nail psoriasis. I often use for nail psoriasis methotrexate, and it's proven to be very nice. Even acitretin at times gives results. Yeah,
very right, Sanjeev.
Considering the fact that nails are the laggards, you see the clinical response late.
Right.
How long do you give it?
You mean to say methotrexate?
Yeah, methotrexate or any systemic drug for nail psoriasis. How long do you give it?
Right. So methotrexate, we have got a very, long experience of giving methotrexate. It is one of the largest, series of methotrexate, which was carried out over 6 years period in PGI Chandigarh. And we published in pediatric age group as well as in elderly. There was, separate publications. And we continued giving, methotrexate for up to 4 to 5 years in many patients, in which the cumulative dose was not much. We gave methotrexate holidays also in between. And another very interesting observation, which often we tailor-made according to the patient's requirement, we give methotrexate holidays for 3 to 4 months. And, there was an article in American Journal of Gastroenterology long back, more than 2 decades ago, that, in an experimental animal, in rabbits, hepatocyte, methotrexate stays for maximum 116 days. 116 days is more or less 4 months. So what we clinically do, it is justified by, animal model study that give a holiday of methotrexate for 4 months. By that time, it gets cleared from the liver.
Thanks. Though we have rheumatology friends who have, in rheumatoid arthritis, used it for up to a decade.
Yes.
I know people who have given 8 to 10 grams cumulative dose,
Right.
and they only monitor regularly.
True. Very true.
Now, coming to pediatric age group, a few points like efficacy vis-a-vis adult patients. Youngest age, we heard from Dr. Sandeepan, well, like to know from others. And how do you schedule the vaccinations with cyclosporine? And what is the dose that you prefer in children? Same as adults, or if they respond faster, do you give a lower dose? And in children, how long at a stretch? And how well do you monitor? Because many of the children would not be very happy getting poked for blood investigations periodically.
True.
So these are very practical points. I would like you to give your opinion now.
I think Carsten can start.
Yes, please.
Yeah, so from a dosing point of view, adults versus children, no difference for me.
Yeah.
Vaccinations, I mean, you want to avoid all live vaccinations, but inactivated vaccines are fine with immunosuppressive drugs, in my experience. How long at a stretch? I have not used cyclosporine for longer than a year in my own practice. That's not to say it can't be done. It's just that I haven't really needed to with the new drugs that are now available. Monitoring and screening, we see patients 4 weeks into physically 4 weeks into treatment, and then 3 monthly. We currently do for the first month fortnightly bloods. So at 2 weeks into treatment, then at 4 weeks, and then 3 monthly. And the youngest age, I don't think there are any particular restrictions there. But in my own practice, I haven't used cyclosporine in anybody younger than 3 years.
All right. Dr. Sanjeev?
Well, I've used cyclosporine above 1 year of age, and even like Sandeepan mentioned, sometimes even younger children, but younger children normally don't come to us with such a severe variety of psoriasis or with atopic dermatitis. It's not very common. But over 1 year of age, I do use it. I even tend to use a little higher dosages because it is much better tolerated. The bioavailability is much better in children as compared to, and safety profile because of the shorter bowel length, the dose is comparatively safer to give in children as compared to that in the adult. So I'm very fond of giving it in children, but the only thing is I find GI upsets in children as well. And that's the only restriction for me, the GI upsets. I mean, I do find them in children.
Do you have any resistance from parents when you tell them to go at monthly interval and then every 3 months for blood investigations?
There is a resistance, but if the child is doing well, that resistance goes out, and success has its rewards.
Dr. Sachin?
I think I can't agree with, I can't agree more than what Dr. Carsten has said. I think exactly the same. The only challenge that happens on long-term basis is when these children have regular vaccinations, especially in very young children. Because live vaccines you can't give, you'll have to stop cyclosporine, a few weeks and then start again.
For how many weeks? That's one. And then
again, there is no standard guidelines for that, but they say it should be stopped at least a week prior and should be started at least a week later. But 2 weeks is actually
It's about 3 months.
preferable. Preferable,
3
but
months.
no, 3 months. 3 months vaccination stop does not happen. You know, that's what they say.
For a live vaccine,
but it does not.
Yeah.
I understand what you're saying, but it's not always practicable that you start cyclosporine and say your vaccination is due. There is immediate disease flare up the moment you stop cyclosporine, and so it's not always practicable. So what we do is stop 2 weeks prior, and then sort of try to replace with other drugs, and then start with after about 2 weeks again. Maximum 4 weeks you can stop. You cannot stop a drug for about 3 months, and that is a challenge in young children. And therefore, I have reservations in starting cyclosporine, especially less than 5 years who are on regular vaccinations.
Dr. Abhijit?
Yes, sir. As far as efficacy and dose is concerned, hardly has any difference between adults and children. Regarding youngest stage, I have used even at 6 months of age, but that is that I have learned from Dr. Dhar only. Better not to start before 3 years of age. By that time, most of the vaccines are completed. So better to start after 3 years of age, but in a desperate situation, you have to use it. And regarding vaccination, if you are opting for live vaccine, better vaccinate, wait for 4 weeks, then start cyclosporine. Or if the child is on cyclosporine, stop it, wait for 4 weeks, then do the vaccination. And please, we should, or we all of us should clearly mention on our paper that vaccination should not be given for 4 weeks or when the baby is on cyclosporine, only for medical legal purpose. Otherwise, you will be sued at the court of law. And regarding how long, I have used it up to 1 year of age. I totally agree with Dr. Carsten. But in many cases, I got good amount of success while I have used it for 3 months or 6 months. Regarding monitoring and screening, yes, Dr. I totally agree with Dr. Kandari. If the success is there, definitely parents will follow you. And if before starting cyclosporine, we should counsel the parents in a detailed fashion. And if we are able to explain them the gravity of the situation and why cyclosporine is needed, what would be the course of the treatment and prognosis, then most of the cases they actually support us, they remain with us. That's all.
So I agree. Most of the times we should try and use intermittently for 4 to 6 months at a stretch, and then take a holiday and then give it again.
Yes, sir.
For safety, and that usually helps. Then you can use a milder molecule. And regarding the investigations, I have learned to investigate for tuberculosis because I find cyclosporine to be a potent immunosuppressor. So probably it is from an era when the rules were not so strict about what monitoring should be done, what screening should be done. And I've seen a couple of cases of reactivation of tuberculosis in my practice. And it's not always pulmonary tuberculosis. I would like to have the view of panelists upon this.
As I mentioned in my presentation, Sushil, that I do not do routine screening, but yes, when there is a family history of tuberculosis or tuberculosis contacts, when there is a past history of tuberculosis, you said reactivation, very true. And probably we missed out on taking a history of tuberculosis in the past. So, in such patients, you have to be extra careful of doing a tuberculin gold ferron test, and chest X-ray. And if needed, you have to repeat it after some interval. But by and large, for all patients, I never do tuberculosis. I think that is over investigation.
No, because we do that for biologics, and most times we don't see any reactivation. But 20%, at least 20% of Indians have latent tuberculosis.
Yes, true. But that latent does not manifest in most of the cases.
No, true. But when you use an immunosuppressive,
right,
you have a potential of causing activation of the latent tuberculosis.
That is true.
Hardly ever seen tuberculosis getting activated, honestly.
Exactly, Sanjeev. That is what I was referring to. And the other thing which I would like to add my own opinion about stoppage of a live vaccine. What Abhijit said, that is something which is written in standard textbooks and journal. But in my opinion, and this is also mentioned in the literature, what I am saying, not that it doesn't have a reference. By and large, when you are contemplating giving a live vaccine, stop cyclosporine 2 weeks before and start cyclosporine after giving vaccination after 2 weeks. What Sachin said, I fully agree with that. And for all practical purpose, this is what advice I got from my pediatric immunologist and vaccination, pediatricians or all vaccination experts. So they also feel that this approach is more or less correct.
For inactivated
Sir,
vaccines,
Sir,
the efficacy may go down. That's all.
Sir, can I
If you
just
don't take a break. Yes, Sachin.
As far as tuberculosis is concerned, I think I agree with you, technically, but in my about 30 years of practice, I've never seen a single activation of tuberculosis happening.
That's right.
Because of cyclosporine. Not me. I mean, I'm sure you have observed it, but I have not seen a patient coming back saying that after because we actually give it for a short while. And I have not seen, maybe actually I may be missing out. I don't know, but this is an eye opener if I'm actually missing out. But nobody has come with fever or cough saying that it's got activated. But it's a good thing to observe in future.
We have
I'm not
heard
sure.
Dr. Sandeepan using it for 8 months and 9 months at a stretch, which is not a short
Yes.
duration.
Yeah, but I have not seen any activation. I don't know.
All right.
I mean,
Sir, may I come in? Sir, may I come
Yes,
in?
please. Yes, please.
Sir, probably I am the junior most among all of you. Still, I have been using this molecule for at least 7 to 8 years, even if not more. But the question is that we all have the same opinion that hardly it reactivates even if the quantiferon TB Gold comes positive. But the question is, how could we stand in the court of law? If it is positive, will you start it or not? That is my question.
Yeah, so I be careful nowadays because I've seen 2 cases of reactivation, and medically, I will not be very safe if I still give it without any
If it comes positive,
prophylactic
just like
treatment. Yeah, if it is positive,
tofacitinib, we do not start. If quantiferon comes positive, then what should be our stand in case of cyclosporine? If we do it regularly and in few cases it comes positive, then what
That
should
is,
be our stand?
so Abhijit, here lies the importance of having our own data and our own guidelines. This is exactly what we are looking through Society for Eczema Studies, because these guidelines cannot come from the West, where tuberculosis is very low, if not nil, in most of the countries, right? So the guidelines which are given by the Western countries, UK or USA, is not applicable to India. Tuberculosis is a problem of India. So we have to have our own data and own guidelines on the basis of our data. So then only you can say, well, it is safe or it is not safe. The tuberculosis quantiferon gold test should be done or not done. Manto should be done. Chest X-ray should be done or not done. In an individual case, nobody can challenge you in the court of law, even if the patient becomes TB positive, and you treat the patient with anti-tuberculosis therapy. They work so well, you stop cyclosporine. There are so many uneventful events can happen with cyclosporine. That does not mean you will stop giving cyclosporine. That does not mean you won't drive car, on the road, because there are high incidence of road accidents.
Right, sir.
So anyway, in view of the brevity of time and we have to cover many more points, I just want a one-line answer. Is it your first-line drug in pediatric severe psoriasis and severe atopic dermatitis?
I think that's a difficult question. My answer is no.
Fine. Not even for severe atopic in pediatric, not even for severe.
Not first line. Not when the patient walks into my chamber, no. I think the other drugs, milder, topical steroids, emollients, antihistamines.
Fine. So we had a one-line answer. Now, Dr. Sandeepan.
It will depend on, this is exactly what I was trying to come in, and I forgot it.
Severe. I
got. For severe psoriasis, I think the quality of life of a child, or say for example, adult, is extremely important. As I have showed, the child was not allowed in school. Similarly, the society behaves in a very funny way with such child. So this is not the trauma for the child, not the ostracism of the child, but it is the trauma for the parents. So I won't be hesitant to use my best possible arsenal to bring down the severity of the disease, and that is cyclosporine.
All right. So if the DLQR score is more than 10.
Yes. And
All
let
right.
me tell, of course, now the priority is going to change probably next few years with dupilumab being now approved by DCGI, and those patients who can afford dupilumab, of course, I will try first with dupilumab in them. I shall start. That will be my first line of treatment. But
And
at
by
the same
February,
and
by February next year, we'll also have abrocitinib.
abrocitinib also. And here must add one thing. So whatever dupilumab, other things which you will see in many trials, so people cannot afford it all over the world. It is not only in India, all over the cost is so exorbitant. So in between, as a dupilumab, sparing agent, people are using cyclosporine or methotrexate. So we are coming back to square one. So cyclosporine and methotrexate still have a role, and it will have a role, whatever biologics and small molecules may come in future.
True. So in Indian context, we know we wish we had more molecules, but in view of the fact that we lack those molecules, we still use a lot of methotrexate, we still use a lot of cyclosporine. Dr.
Right.
Sanjeev?
Yeah, I
And
would
Dr.
tend to
Abhijit?
agree with that one single statement. I would use it if required as a
All right.
first line. I would use it.
All right. Thank you. And Dr. Abhijit?
Yes, my only answer is, sir, yes. If it is extremely needed and severe case, only topic will not do here, sir.
So what about the cyclosporine as a part of combination therapy? We know the logic, but what would you prefer as molecules
Dr. Sandeep, Dr.
in
Dr.
combination?
Dr. Sushil, I
Yes.
would like to hear from Dr. Carsten what view he has. Will he start or not in UK? I mean, what do they do in UK?
So
This is
he
talking
has
about
already said
combination.
that he,
You mean combination therapy?
no, he wants to
starting
know
cycle.
from you in previous question.
Oh, I see. Yeah, I mean, I gave it to you in my talk. I guess it's if unless there's a really severe flare, which could even be infection driven, where I would resort to cyclosporine. It's definitely methotrexate. These children usually have had very severe atopic dermatitis for years, and that small difference in the objective score we saw of being sort of 6 points better at 12 weeks than the cyclosporine compared to the methotrexate group is not big enough for me to go to cyclosporine in most cases first and then switch to methotrexate. It would be it have to be a case of extreme as well to use cyclosporine first.
Thank you. So I would like to know from panelists logic. We know the logic. What are the molecules that you'd prefer if you want to combine those with cyclosporine? And what are the molecules you'd like to avoid, and the ways of treatment that you'd like to avoid? And if you use oral cyclosporine, in the use of topicals, would you have any restrictions vis-a-vis, supposing you're using cyclosporine, topically used topical calcineurin inhibitors, both with the same, do you have any reservations or no reservations?
Can I come, Sushil?
Yes, please.
As far as cyclosporine is concerned, combination of cyclosporine with topical steroid and topical calcineurin inhibitors, they are well recommended. So the only serious contraindication with cyclosporine is phototherapy. That is the and the reason we all know. Now it's more of sequential therapy rather than combination therapy. But as I mentioned in my lecture, talk, as well as Carsten repeatedly said this, often we need to combine cyclosporine and methotrexate or cyclosporine and steroid at the beginning for initial few weeks, then stop steroid, continue cyclosporine, or then after a few months stop cyclosporine, continue with methotrexate. That is another good approach.
What about acetretin?
Acetretin and cyclosporine, I won't like to combine because both have, action causing dyslipidemia, which can be havoc. So I won't combine these two.
Other panelists, please.
Agreed.
I think we agree with Dr. Sandeepan completely. Cyclosporine, when you're tapering cyclosporine dose, I think you can add 7.5 milligram of methotrexate, because methotrexate takes a little time, as he has shown. Then methotrexate can take over and you can stop cyclosporine. Steroids can be combined initially, but I think steroid combination is again risky because both are strong immunosuppressive. So I would be a little scared of combining both of them together for risk of infections. As far as acetretin is concerned, acetretin again is a slow-acting molecule, and hyperlipidemia is known. Phototherapy should not be combined as much as possible for the risk of malignancies. I agree with Dr. Sandeepan everywhere.
And mostly, I don't combine it with biologics.
So
Yes,
they are not supposed
can't
to
do,
be
yes.
used together.
Yeah.
Sir, may I come in?
Anyway, yes, please.
Dr.
Dr. Abhijit.
Carsten, yeah.
Yeah, Dr. Carsten, please.
Yeah, sir.
Combination therapy. I mean, if you're wondering about systemic drugs, I mean, maybe is worth in the atopic dermatitis contracts combining systemics. It's certainly not my practice to combine cyclosporine with methotrexate. I mean, that would be there's no need for that. But what I have needed to do occasionally now is where children have not responded adequately to dupilumab, and where they're under 12, because I have no JAK inhibitor that's licensed under 12 years of age, I've added in methotrexate. And that has helped in some cases. I have one child, but that's going off piste a bit in terms of this discussion, that is on combined dupilumab and abrocitinib therapy and is doing very well because she was not adequately controlled by dupilumab plus methotrexate, even. So dupilumab alone, dupilumab plus methotrexate, and I had to then resort to dupilumab plus abrocitinib. But generally, I'd be cautious about that. And as I said, I only use cyclosporine ideally for a short period of time, so I wouldn't really usually entertain a combination of cyclosporine with another systemic therapy. In terms of topicals, I don't really have any particular restrictions there.
Dr. Abhijit.
Yes, sir. Definitely, again, approach should be approach varies from patient to patient. Obviously, if you ask me about the systemic molecule, I couldn't agree more. Cyclosporine followed by methotrexate, not as in combination therapy. In most of the cases, cyclosporine really works well. We need not to combine anything in most of the cases, not all. And obviously, sequential therapy is much more preferable. But only one catch is that in older individuals, we should be a bit cautious because their glomerular filtration rate is much more less. So when you are switching over from one molecule to another, from cyclosporine to methotrexate, there must be an overlap of 2 to 3 months. By that time, you can decrease the cyclosporine doses, and at the same time, gradually methotrexate is taking over. So in that period, we should be a bit cautious as far as the glomerular filtration rate of the older individual is concerned. And again, in certain patients, you need not to give methotrexate, only simple moisturization, liberal moisturization will do. But in that case, this is a advantage that if we moisturize the baby from the very early stage, from the day one, maybe we need cyclosporine for 2 to 3 months in the next year. But by that time, with proper moisturization throughout the day, throughout the course, even during maintenance phase, will reduce the requirement of cyclosporine in the next phase. So this is one advantage of using topical moisturization properly, liberally, multiple times. Molecule, obviously, acetretin hardly it requires. Most of them are hepatotoxic and may cause hyperlipidemia. And the reason is very simple. Cyclosporine, most of the cases, works very well. So why we should unnecessarily increase the toxicity? That's all.
The point well taken. Combination in literature has been done of, like Dr. Sandeepan said, methotrexate and cyclosporine combination in very severe cases of psoriasis as a poor man's biologic. But if you use it for 4 weeks, then many times you see risk of side effects. So monitoring has to be more aggressive. And when you combine with acetretin, you do it in a sequential mode during the transition phase. You start with cyclosporine, then you introduce acetretin and gradually withdraw. They say, in fact, this combination has a mutually exclusive side effect profile except for the effect on the lipids. So you could start with one, then into a phase during which you use the two, and they withdraw cyclosporine and continue the acetretin in psoriasis. It is mentioned in the as a standard way of treating.
Sir,
And of course, we agreed that we should not be combining with phototherapy. We would like to avoid biologics and cyclosporine together. But coming to combination of JAK inhibitors in bad cases. Any comments? Because in the literature, this combination has been used for non-responsive severe cases of ulcerative colitis.
Yes.
Cyclosporine and JAK inhibitors together.
Great.
So any potential use in dermatology?
sir, may I come in?
Yes, please.
Regarding combination therapy in general, it is always better to choose two drugs if we at all need to do it. Then better to choose two drugs which has different end organ toxicity. I mean, if one is nephrotoxic, then another should not be nephrotoxic. Likewise, if possible, we need to combine in that fashion. And regarding JAK inhibitor and cyclosporine, again, that would be too much. There would be much more chance of severe immunosuppression. And I'm totally agree with you. When the patient is not responding to cyclosporine, in that sense, cyclosporine resistant case, if we say in that fashion, there JAK inhibitors has some role. Even
Yeah, so in extreme cases. Yeah,
I have used multiple cases of alopecia areata, alopecia totally, sorry, where I've started with cyclosporine, didn't got any response even after using for 6 months at a stretch. Then I switch over to tofacitinib or other. There I got positive response. So in those cases, my indication would be when I'm not getting response with cyclosporine. In that cases only I would use JAK inhibitor, not as a combination therapy.
Your logic, there's one more logic. When you use cyclosporine methotrexate has an effect on the liver, and that is a place where cyclosporine is metabolized. And cyclosporine has an effect on the kidneys, which is a place where methotrexate is excreted. So that is one objection regarding combining these two.
Yes, sir. Definitely.
There I think, logically also, JAK inhibitors and cyclosporine, to my mind, should not be combined. Because
Right.
of the,
Thank you.
though there is a reference in, very severe ulcerative colitis, they had to combine. But see, there are a lot of side effects of both JAK inhibitors and, cyclosporine, which will be cumulative, like on platelet count, like on WBC count, like hyperlipidemia. So both of them can create more of combined, adverse effect, much more than the actual efficacy for the reason or for the disease for which it is actually combined.
Thank you. So it's very good that people get a clear message. That was the reason why this topic was brought out. What about, we see hypertension as a side effect, renal nephrotoxicity, dyslipidemia. But in real life, we see patients who need cyclosporine. You wish you could write, and patients have suffered from hypertension. Is there a absolute no-no, or there are some cases where you would still use it and judiciously? And how would you use in such cases?
Dr. Carsten, you would like to comment on that?
Yes, please.
Again, I'm almost apologetic for not sounding so enthusiastic about cyclosporine. Yeah, no, exactly. I mean, you've got other, but I appreciate your perspective, and in your setting, you may not have the sort of breadth of treatment options available. But yeah, I mean, generally, I would steer away from immunosuppression in most of these. The superficial fungal infection, well, I'd treat that first and get that sorted, and then you could use it. But if you've got signals like hypertension or impaired renal function, or indeed dyslipidemia, I would see that as a certainly relative, if not complete, contraindication to using cyclosporine.
Yeah, you use another drug. Why go on using that drug? I mean, it makes no sense.
Exactly. Can I come in here, Sushil?
Yes, please. I want a clear opinions.
Yes, my approach is very clear. I, tell the patient to go to a good cardiologist and if needed, an endocrinologist also. I think these are all relative contraindications, not absolute contraindications. I have so many patients who are hypertensive, their blood pressure was not being controlled, but when they had seen a super specialist, a cardiologist, blood pressure has been nicely controlled and cyclosporine still can be given. So hypertension is not a no-no for cyclosporine, never. Neither the renal impairment. Even in renal, then if it is renal impairment, how for renal transplant patients, they are giving lifelong cyclosporine, right? So I think these are all relative contraindications. You have to reduce the dose of cyclosporine. You have to look at the GFR at a regular interval, not the creatinine, but creatinine clearance values. So by proper monitoring, that's why I repeatedly emphasized on monitoring these patients properly. So under all circumstances, dyslipidemia can be very nicely taken care by a cardiologist or an endocrinologist by giving one of the statins for dyslipidemia. And cyclosporine also, I have many patients. They are having dyslipidemia, but their lipid profile has been normal with statins. And cyclosporine, except there are few statins which cannot be given for rhabdomyolysis if it is given concomitantly with cyclosporine. Other statins can be given.
So, Dr. Sachin, you have something to say, or I can just sum it up by saying that in hypertension, they say, unless if it is a refractory malignant hypertension, you can use calcium channel antagonists. That's a drug of choice.
I think my understanding is that these stronger immunosuppressives, you have to have a little conservative approach, for at least for the juniors, in the sense that it can't be just used routinely on all cases. In a very severe case, exceptional case where it is not responding, the patient is suffering, and the side effect to benefit ratio is far outweighing everything else, then it's okay. But I would be extremely hesitant with patient walking in first time to my chamber, no matter how severe the psoriasis is or eczema is, to straight away start on cyclosporine. I mean, in a resistant case, yes, but in a first time, I would be extremely hesitant. So my view is a little more conservative, but I think that is how I would do.
Correct. So where they have to use it, the hypertension is better managed with the calcium channel antagonist. Regarding impaired renal function, when you use the monitoring, and if the creatinine goes up by 25%, even if it is within normal range, it's supposed to be nephrotoxicity. So you don't have to look at the range itself. Supposing initial value is 0.8 and it goes to 1.1, that is significant. That's a message people should get, even though the normal may be up to 1.4. And while managing dyslipidemia, patients should be given not simvastatin, but probably rosuvastatin, which does not work on the cytochrome 3A4.
Agree.
You agree? Yes. And challenge comes in superficial fungal infections because when you're using itraconazole, it blocks the metabolism of cyclosporine. So cyclosporine values actually go up, levels go up, and the risk of side effects is more. Now, challenge comes in a lot of atopics who come to you with warts and molluscum contagiosum, and they need cyclosporine. So when you look at this, is it good that they are given or bad that they are given?
Dr. Carsten?
Dr. Carsten, because, So again, Dr. Carsten said that he has got better molecules at his disposal.
No,
Sandeepan. Yes, Dr. Carsten.
Now, sorry, I missed this point.
So when patients with atopic dermatitis, many times on areas which are eczematized, we see a cluster of molluscum contagiosum. We see a lot of verrucae. So when you have to use cyclosporine, would you be causing immunosuppression, or would you improve the barrier function? Therefore, the
again, because cyclosporine I rarely use, certainly in methotrexate, which also has a degree of immunosuppression, of course. I wouldn't see that as a contraindication to using the drug. As barrier function improves, very often the infections go as well. I mean, that's more seen in patients switching from an immunosuppressive drug to dupilumab, for instance, as well. But yeah, I mean, we can have sometimes have really persistent molluscum or viral warts in these patients because their barrier function is impaired. but yeah, I mean, it's that is, as I said, I think I did answer that earlier. I don't think that's a strict contraindication for me. It's the other,
Thank you.
the
That
other.
is a clear message, Dr. Sanjeev.
Yeah, I would agree with Carsten, and I would also treat the molluscum. What is there? You just take them out.
Dr. Sandeepan.
Yes, fully agree whatever have been said.
So, in fact, sometimes when we improve the dermatitis, the autoinauguration goes down.
Yes,
That
exactly.
they increase because of autoinauguration more than the immunosuppression.
Absolutely. And second thing is that improvement in the barrier function with cyclosporine or methotrexate, you improve the barrier function, and the molluscum contagiosum, which were there earlier, you were expecting that will increase or flourish. That does not happen, in fact. And what Sanjeev said, I fully agree. Simultaneously, you treat molluscum contagiosum, do chemical cautery with
Cautery or freeze them. What is there?
whatever it is. Yeah.
Thanks. So these are day-to-day situations. So therefore, people who are linked should have a clear message about how the experts here manage their cases.
Sir, may I come
So
in?
I just want to know off-label any conditions which are not there in the literature, any short-term or long-term users in your practice. Unusual cases.
Sir, you rightly mentioned, Steven Johnson's and 10 for a short duration. That is a very, very great indication now where you don't want to give steroids. It can be used. Then, of course, sir has already covered pustular psoriasis, erythroderma, severe atopic dermatitis. So these things are already covered. But drug reaction, urticaria, angioedema, I think these are areas which again are very enterprising and very, very rewarding actually.
Pyoderma gangrenosum.
Very,
Sir, may I come in, sir?
Yes, please.
I'll request Sushil to, if you could wind it up in 5 minutes time.
So I think we are almost there towards the end. I thought.
Sir, okay, may I?
Yes, Dr. Abhijit.
Yes, sir. Of late, I have been using it for erosive boral lichen planus. It's working like wonder. And with that extrapolation, I also have used it in certain cases of erosive gingivitis, where it worked very well. So these are my two new off-label indications where I have been using for some time.
Some of my patients of Haley and Haley have responded to it, So from that perspective, it's not a bad idea to try and use it there.
Dr. Sandeepan, any other indications? You said you have got a wide range of indications.
Yeah,
any
I think, yes, prurigo nodularis consistently respond to cyclosporine.
Yeah, wonderful response.
It's a wonderful response, but the problem is that if you the moment
stop
you stop
it comes back.
Within a month it comes back. Actually, that is the shortcoming of it. The other indications where I used to use earlier, oral steroids. Now I have switched over, like generalized mastocytosis, where you have to give not only antihistamines, but you have to give for such extensive lesions. Earlier I used to give 15 years ago, 20 years ago steroids. Now I have switched over to cyclosporine. I see there is fairly good control with limited 4 to 5 months of cyclosporine. But only issue that many of these children are below 3 years of age. I try to avoid in them. The other conditions where I have used cyclosporine, is a range of collagen vascular disease. Say, for example, SLE, dermatomyositis, where cyclosporine has taken over from steroid for the initial control of the disease or acuteness of the disease, then switch over to long-term maintenance treatment with either methotrexate, mycophenolate, or cyclophosphamide. I wanted to say that with azathioprine, my experience is also very bad. As Carsten mentioned his experience, I not only for this long-term risk of malignancy, in two of my patients, one had bone marrow suppression, one had very extensive infection to the extent that the patient had to be admitted in an ICU setup. And cyclophosphamide, I never give in a child or in an adolescent, because if you give a cyclophosphamide, then sperm bank and all these issues will come, which has got a grave medical legal significance.
Sir,
I have also been, using in many of the severe bullous fixed drug eruptions, and in acute contact dermatitis when people have a steroid phobia, you give them 5 days or 7 days course of cyclosporine, it works very well.
True. Agreed. I also use it.
Sir,
I also use
Yes.
it.
picture is,
Abhijit.
picture is quite similar with lichen planus hypertropicus, as sir already mentioned, like prurigo nodularis. Extremely resistant lichen planus hypertropicus, not responding to anything, methotrexate, acetretin. Those things respond to cyclosporine to some extent, but again, whenever you taper down the dose, again the flare comes. That's the problem.
Intralesional steroid DJ, sir.
There was a very interesting study on oral cyclosporine for erosive lichen planus in the mouth. Swish it 5 ml each time, 3 times a day, and then spit it out. I found it to be the most expensive spit in the world, you know.
Yeah.
If you do it 15 ml per day.
I think
Better
Sushil, we
to
should
give oral,
wrap
sir.
up. Sushil, we should
No, but if you
wrap
don't
up
want to
now.
avoid a side effect, just spit it out, you know.
I think we should
Yeah,
wind it up.
yeah. Just summarizing, any points that make this molecule unique and indispensable. Pregnancy category C, in dire circumstances, we can use it as rescue therapy or crisis buster where nothing else would work that fast. And you normally don't see immediate life-threatening adverse drug reactions. I wanted your opinion on this. Would you agree with this?
Yes, agree.
Yes, agreed.
Yes.
Yeah, definitely. I mean, pregnancy is a good example where cyclosporine is well established as a safe therapy. Where you've got, even for the novel therapies, you've got clear on the label of these drugs, even for dupilumab, which we've had some healthy pregnancies, but it says clearly on the label, do not use in pregnancy. So yeah, that's a good example where cyclosporine is useful.
I think I agree completely. Yeah.
I just wanted Dr. Sandeepan's closing remarks on when we talk about atopic march. When we see a child with extensive atopic dermatitis with inflammation on the entire skin, why is it there's no risk of cytokines getting absorbed and causing a systemic comorbidity? Why should we call it a march? Is it a systemic disease or a skin disease alone? Like psoriasis, we call it a psoriatic disease. Anyway, Dr. Carsten, would you like to agree that even atopic dermatitis is probably a multi-system disease which comes to dermatologists because of the severity of the skin involvement?
Yes, Carsten, you can take it up. Then I'll
Depends on what you mean by multi-system disease. So I don't think atopic dermatitis by itself is necessarily a systemic disease in the restricted sense. So it becomes systemic through, for instance, very severe itching, sleep loss over many years, associated comorbidities like anxiety and depression. But then statistically speaking, of course, a lot of our patients have got asthma and hay fever and food allergies.
I wanted to come to asthma and hay fever.
Yeah.
It is,
I mean, cyclosporine, I'm not aware of cyclosporine as a good treatment for asthma or hay fever. So whereas dupilumab, of course, ticks those boxes very well. And that's one of the add-ons. Methotrexate wouldn't do very much for your asthma either.
Right. So it is basically, in that sense, is not a systemic disease, but yes, there are a lot of systemic comorbidities, including obesity. Earlier, you used to say obesity is a risk factor for psoriasis. Nowadays, it is said even for atopic dermatitis, obesity is a risk factors. And the events happen sequentially, unlike psoriasis, when psoriasis and psoriatic arthritis occur together. Here, as you said, Sushil, the atopic march, which appears at different ages. So that is one thing. And second thing, yes, I agree with Carsten that I also don't think the cyclosporine can prevent the atopic march, or it is a good drug for asthma or hay fever. But yes, dupilumab is because it is used in asthma also, because it was first published by the respiratory physicians in New England Journal of Medicine way back in 2013. And then in next year, in 2014 only, the dupilumab studies came in NEJM. So both the pulmonary physicians and the dermatologists are getting benefit out of it. Moreover, eosinophilic esophagitis is another, area where dupilumab comes very handy as far as the treatment of choice is concerned.
All right.
Sir,
Thank you
may I
very
come in,
much.
sir? Sir, may I
Yes,
come in?
please. Yes, please.
Actually, we are moving towards the more and more targeted therapies. And if we talk about the biomarkers, though those are very limited, but on research level, we have TSLP as a proposed biomarker. So if in next for 10 to 15 years, if we got TSLP blocker, which is found to be an independent risk factor for both asthma and atopic dermatitis. So if we get this kind of molecules, probably we can prevent atopic march in that sense.
With that, I would like to thank all my panelists, and I apologize for having exceeded my time, but I'm sure it was a very interesting and very informative discussion. And I hand over the mic to the Biocon team for closing the function.
Dr. Sandeepan Dhar, sir, over to you. Thanks, Dr. Sushil. Yeah.
I think we have lost him, have we?
It looks like.
The screen is frozen.
Network.
So probably
Dr. Carsten can have the closing remark. He comes all the way from UK.
I feel very honored. Well, thank you very much. It was delightful being part of the discussions and to exchange our views. Interesting to hear about different practices, but also to hear that we're doing things in very similar ways as well. So no, that was really, really nice. Thank you everyone for their contributions. Sandeepan, you've got the last words. We've got you back. Hooray.
Yeah, so I got disconnected in between. So I, wanted to thank all the faculties about whom I have already mentioned. I'll repeat it because Sushil was not that time connected. Dr. Carsten.
Again, he is frozen.
We've lost him again.
Dr. Ovisa. Can you not hear me?
Yeah, we
Yeah,
can
Can you
hear
hear
you.
me?
You're audible, sir.
Yeah.
So we want you
You're
to
audible.
give us the
Uh,
closing remarks now.
Right. And sincere thanks to all the participants. We have exceeded by half an hour, but still we can see, the good number of participants are eagerly listening to the discussion. So that speaks volumes about the quality of discussion we had. And I sincerely thank the entire Biocon Biologics team, Mr. Chetan, Dr. Neera Gupta, and Mr. Varun Kumar and entire team for supporting this event, as well as for all kinds of support for Society for Eczema Studies. Thank you very much. Good night, everybody.
Thank you, Sandeepan, for inviting
you.
us. It was
Thank
enlightening.
you. Thank you. Bye.
Good night, all.
Thank
Good
you.
night.
Thank
you.
you,
Bye
Dr.
for now.
Carsten. Thank you,
Yeah,
Dr.
bye.
Sandeepan.
Thank you.
Thank you.
Bye.
Good
Bye-bye.
night.
Thank you very much, everybody.
Good night.
Thank you.